Okay.
Okay, so good morning everybody. Welcome to Governing Body. Welcome to members of the public to Barsey CCG Governing Body meeting in public. Housekeeping, you're in your own individual environment, so I suppose the thing is make sure you're safe, and can we observe the MST etiquette, raising hands if people wish to speak most of the time, please. So apologies, Kay.
We have apologies from Dr. Harben and Dr. Kadasha.
Okay, and we're quorate.
We are quorate.
That's good. So patient story, please, Jane.
Thank you, Chair. So this week marks Dying Matters Awareness Week, which is focusing on the importance of being #in a good place to die. Research carried out by Dying Matters showed that just 13% of adults say they've let a close friend or family member know where they want to be when they die. And just 3 in 10 know how to make arrangements to ensure they die in the place they would wish to. I'd like to introduce you to Lisa, who will share with you her reflection on her friend's end-of-life care and how she was able to die in the place that she had chosen. So thank you, Lisa.
Hello, my name is Lisa, and I'd like to talk to you about my close friend Mary and the end-of-life care that she experienced earlier this year. I was close friends with Mary and her family for many years, and towards the end of her life, I watched her getting more and more frail due to her age and heart problems. When Mary was admitted to hospital last year with her heart condition, she was told that she was too frail to have surgery. She knew that the heart condition was going to get worse and that she was going to die in the near future. She told me that she'd accepted this situation and was adamant that if her health got worse, she didn't want to go back into hospital again, that she definitely wanted to die at home. She even had her do not attempt to resuscitate form hanging in the hallway so that everyone would see it when they walked in through her front door. And when I asked her if anybody had spoken to her about her end-of-life wishes, she said that no one had spoken to her about it. When she was discharged to a care home for respite, I know that Julie, her daughter, did telephone the home as soon as Mary arrived to let them know her wishes. And she even left a telephone number for someone to call her back, but they never did though. And the home just told Julie that if her mum became unwell, that they'd just phone 999. And it was only after Mary had been discharged home that she was handed over to the palliative care team. However, I did notice that in her records at home, there was nothing to let medical staff know her wishes about how she wanted to die. The carers told Julie that they'd just have to call, they'd have to call 999 if she deteriorated. And we were really, really upset about this because we knew that that's absolutely not what Mary wanted. And a few days later, a nurse called saying that she'd have to admit Mary to hospital the next day because she'd had problems with her legs. And Mary and Julie, they were really upset about this because Julie told me afterwards she thought Mary would definitely have preferred to have stayed at home. If they'd had better communication of Mary's wishes to die at home earlier, it would have saved so much upset for Mary and for her loved ones. And once she'd come back out of hospital, one of the care team phoned Julie and said that the carers were now aware that Mary was for palliative care and that they definitely wouldn't phone 999. They said they would ask the palliative nursing team for advice instead. Mary soon started to feel really sick, and I did ask one of the nurses if it was probably the antibiotics that she was on for her leg. And she ended up having an injection to stop her feeling sick. I spoke to the nurse again, who then called the GP, and the tablets were also stopped. Not long after that, Mary got worse quite quickly. And seeing how Mary was cared for at the end of her life, it made me realise how important it is for doctors and for nurses to speak to patients and each other about the care that that person wants at the end of their life, and that this needs to be written down somewhere so that everyone knows. Mary felt like no one was asking her or listening to her, and I'm sure that could have gone differently. Eventually Mary did die peacefully at home with her daughter by her side, and we are really, really grateful for that.
Thank you, Lisa.
Thank you. Any thoughts from governing body? Jane.
Thanks, Chair. For me, it shows the importance of advanced care planning, to listen to the wishes of the individual, so that the individual can say and choose where they want to be cared for in the last days or the last months of life. So for me, it's about the importance of care planning in advance.
Jane, Madhvi?
Yeah, so I was just going to say what Jane said with advanced care planning and communication is the key. And I think it was a little bit difficult through the pandemic because obviously as GPs we work very closely with patients towards their end of life. Of course, it's the means of communication which was slightly different through the pandemic, but the work has happened. And what I'd like to emphasize is the program we are doing with care homes. And how it actually improves the outcomes for patients who are on the end of their life. Because I think what we are doing through this program is actually to be more proactive rather than reactive, and actually do the advanced care planning much more in advance than what we used to do before. And I'm hoping that by doing that, actually most patients in care homes now have got an advanced care plan in place, which is revisited as we go towards the end of their lives. And I think that should actually improve outcomes and much more for people of Barnsley as we move forward.
Thank you. Dr. Addy Cunley?
Thank you, Chair. Thank you for this story, Lisa. What this brings to mind is the discussion of patients' wishes at a very, very early time. When we can identify that this person has got a progressive illness that is not going to get better, then we should start initiating these discussions. And across the IT system we have in Barnsley, and even I think it extends to the ambulance and the hospital too, we have the EPACs where we can actually document these things and patients' wishes there. The ambulance crew can say it, the hospital can say it, everybody can say it. And I think just proactively making that discussion and recording it appropriately helps patients like Mary to, during their end of life.
Thank you, Evo. Chris Millington, you had your hand up?
I did, Chair. I think most of the concerns have been addressed, but over the last few years, I've dipped in and out of the cancer steering group and listened to all of the things that are in place. But it's quite incredible sometimes when you actually get to that point that things don't actually happen. And I don't know why. Certainly one big area of concern I had at one stage was Yorkshire Ambulance Service. But as Dr. Addy has said, hopefully, and I stress that word hopefully, that's now been addressed. So yeah, it is a very difficult situation. I was once faced with it myself with my daughter, with my sister, and she said quite clearly, I don't want to die in hospital, but right at the end, I had no option. I personally didn't know what to do, so I did exactly what a lot of people have done and dial 999. Lisa, it was quite interesting to hear the comment about the DNA right at the at the prominent place at home, because certainly in the past the ambulance service or whatever sort of rush them out and straight to hospital, which is not always what people want. And certainly through Barnsley Patient Council, I've had two particular people who have actually said, look, all of this was in place, yet my mother was on the point of being whipped into hospital, and I actually stopped them doing that. So yeah, we're doing great work. It's important that we do it, but to actually at the point of, I'll say, crunch, it doesn't always work. So still lots of things to be addressed. Thank you.
Thank you, Chris. I think from my perspective, one thing is that people have wishes and they need to be respected, but their conditions can deteriorate rapidly. And sometimes that urgency of planning can't take place within the time that they deteriorate. Sometimes it can be very rapid. I think the other thing is that people's wishes, for example, if they wish to stay at home, does depend quite a bit on the support that they have around them. And we also know that if we make decisions quite early, they need to be reviewed, because that support and carer fatigue comes in and people get worn out looking after people. So I think there's an issue about doing it early, having a conversation, but also perhaps revisiting that if a long time has passed, because things do change in people's lives and environments. But ultimately, I think we want to join up the comms around this to be able to respect people's wishes. Okay, so are there any other thoughts from governing body? No? Okay, thank you. Thank you, Lisa. Then we'll move on to item 5. Declarations of interest report. There is one item 17, about the PDA medicines optimisation, where GPs contracted through the PDA to deliver, and therefore will gain some benefits for the practice. So that's a conflict. So when we come to that discussion, we come to it from a qualitative perspective. Are there any new declarations of interest anybody would wish to share other than that? I'm seeing no. Okay, so can we move then please on to item 6, patient and public involvement activity report, Kirsty, where you're reviewing the strategy.
Yeah, thank you, Chair. So one item on the paper to bring you this month for assurance. So you'll be aware that we have a patient public involvement strategy for the CCG. That was developed probably about 3 years ago now, so it had a shelf life of 3 years, which came to an end this year. So we took that to the Engagement and Equality Committee for a view on do we review it, refresh it in light of obviously the changes that are coming up within the CCG over the next 12 months. So we took the view to do a refresh. We put that back out to members of the public, colleagues, partners, and we also took it to Patient Council, and I think that went in the April Patient Council. So Patient Council were really instrumental in developing the previous strategy. They set out a set of principles for us, which have been really useful, and those guiding principles are what we base most of the activity on, and we return to those when we're thinking, actually, have we got this right? Does this feel like we're doing the right approach when we're talking to members of the public and patients? So they reviewed it in April, and we will be taking that strategy, the refresh of that strategy, back to the Engagement and Equality Committee next week for their review and approval. So once that's approved, we can note that at the governing body meeting. That's the main item that I wanted to share this month. So thank you, Chair.
Any questions or thoughts for Kirsty? Chris Millington.
Just like to reinforce the importance really that we get through Barnsley Patient Council, and two comments in particular which we accepted quite some time ago, which are retained thankfully within. So simple, but it says, I am a part-time patient but a full-time person. And a lady who was very, very insistent on plain speaking didn't insist, but put forward that please don't use jargon, stop using jargon. So, as Kirsty says, this is going for ratification shortly, but I just wanted to pull those out of all the stuff that we have discussed and all the things that we agreed. That's where that's the patient voice coming forward, which I think is great. So thank you.
Okay, thank you, Kirsty. So we'll move on to 7 questions from the public. Did we receive any, Kirsty?
We did not, no, Chair.
Okay, so on that, how does that make us feel? In terms of, through COVID, we've had very little sort of engagement in governing body itself from the public for understandable reasons. And so when I asked you this yesterday, Kirsty, I started to think if there might be something else we could do for July's governing body to perhaps stimulate some interest or contact perhaps some people who we used to hear from frequently, and just to see if there's a way we can facilitate some questions. That's might be opening Pandora's box, but it seems uncomfortable to me to currently have no public questions in a public forum. Can we have
yeah, definitely, and it is something we've been thinking about. So colleagues across other CCGs and also ICS have also been experiencing the same thing, and I think that there's a sort of bigger piece of work here to think about. So we're looking to council colleagues, for example. So council colleagues are running meetings in public virtually as well at the moment. And what they found is actually the engagement from the point of view of people viewing the meetings has gone up considerably, because it offers much more access, but they're not necessarily getting the specific questions. So I think there's a couple of areas that we might want to consider. You know, what do we think is good engagement with these meetings? And certainly the questions do provide a good challenge to us, don't they? So I think that's certainly something to look at in the first instance, but it's probably worth us considering the bigger picture of how much more potentially accessible some of these meetings are to some people. So that's the sort of the view that we would be looking at it from.
Thank you. Mark?
Do we actually have people watch these recordings? Is there any way of knowing that?
Yeah, so we post them on the website. We can see viewing figures. They aren't huge, but they are probably more than the 3 or 4 people that came to Hilda House, or came to the sessions that we did, came to the sessions that we used to do out and about across the borough, because that was one of the things, didn't we? We sort of took the CCG on tour and went out to different areas, and perhaps that's something we can consider, perhaps looking to work with colleagues in the council who are and in our primary care network neighbourhood areas, to think about how we might focus perhaps some of the work on each of the individual areas that might be more interest of people if it's something local to them. So yeah, and also we tweet throughout the meetings as well, so we get questions coming in, so that you may not necessarily see that there, but perhaps it's worth me thinking about it and perhaps doing an update in the patient and public engagement report section, and I'll work with Richard in terms of governance, but just bringing an update back to governing body so you can see sort of the breadth of what we've got now, and perhaps you can give us a steer on where you think we might want to be.
I think that would be good if we can have it in the next book. Yeah, that would be a good piece of work, I think, and it would demonstrate to the public that it's important to us and the efforts that we're making. Thank you, Kirsty.
Thank you.
So then we move on to item 8, minutes of the meeting of governing body 11th of March, and they're here for approval and any clarification. Does anybody have any comments or questions? Okay, not seeing any, so we'll approve those then. Thank you. And we move on to 9, the matters arising report. Any bits on that? It's all done, isn't it? Okay, so is there anything on matters arising? Jeremy?
Thanks, Nick. Yeah, just on 210113, talked about the restoration and recovery plan in there. That's a fairly complex piece of work that we're still in the process of completing. So it's 3 key elements in that. There's the NHS planning guidance and the plan submission, which Jamie and colleagues have been working on, which is now in draft and will be completed by the end of May. Plus work with our local authority colleagues on their commissioning plans, understanding those and aligning them. And then thirdly, our work on health inequalities and a workshop we had right at the end of April, attended by health inequalities leads from all our health and care provider colleagues. So just in the process of pulling that together at the moment, and that should be ready in the next couple of weeks. So I suggest that we bring it back to a governing body development session, so we can share it within the CCG, and we'd be doing, our colleagues would be doing the same thing in their organisations as well, so it becomes a generally co-produced piece of work.
Okay, so next we have Mark.
Below that 21115, the section about the best website, that part's complete.
Okay, and Chris Millington.
Similar question, really, Chair, in that if you remember when we discussed this some time ago, we were told that there was lots of information out there that could be accessed, but 1 or 2 of my clinical colleagues stuck their hand up and said, I've not seen that. If you remember, we then followed that up by making sure that that information was within the GP practices. So what I'm looking for really is assurance from my clinical colleagues this morning that in fact that's happened and it is available and it's relevant.
Okay, so from my GP colleagues, have they seen this? Any of you?
No, I haven't seen it.
No, I haven't, but I might not have needed to use it yet.
Yeah.
So Chris's point is a good one, isn't it? Because it's closing the loop on our actions. So perhaps we should all take an action that governing body members go back and see if this is actually available in practice. It probably is, but we may not have needed to use it yet, or may have gone different channels.
Well, if you remember the summary that we got from Mr. Otway was very comprehensive and very meaningful. But if it's not being used, and you know, we did put a push on it, so I'm not being assured on that. Not today. Thank you.
Okay. So we'll pick that up as an action, Kate, and we've got enough GPs on the governing body to go back and have a look for that. Good point, Chris. The only point I've got is 191103, which was we were considering how the voice of young commissioners could be involved with the CCG and the Health and Wellbeing Board. I just wonder if, given that we're moving into new structures, whether we should try and have that voice now perhaps at the Health and Wellbeing Board rather than at the CCG. I don't know what people think about that.
I think that's a good point, Chair. There's one of our providers getting quite involved now in public and patient engagement, and they threw the challenge out to young people, and when they reviewed the balance of people who were there, yes, there are quite a few people in the 60, 65, 70 age group, but their youngest is 17 years of age. So when we think about Oasis, when we think about Chili Pet, when we think about the college that we've got in Barnsley, when I think about my own granddaughter who's great ambitions to become a paramedic, you know, early in, and it secures people, in my opinion. So good, yeah, good point. Probably there is a bigger and better forum for it than just the CCG.
Okay, shall I take an action then as co-chair of the Health and Wellbeing Board just to bring that up at Health and Wellbeing Board again? I think it has been before, and they all said it was a good idea. Helps inform strategy and keeps us aware of their perspective. And in the CCG, I think we're going to struggle to get that voice to the governing body, but we can have it in the various engagement.
Yes, well, just coming back, Chair. One area of that we can tap into, which one of my contacts was going to try and do, was the youth orchestra in Barnsley, which is very, very strong right across the age groups. So maybe in a different forum we could actually get to some of those people as well. So when we talk about the college, the youth orchestra, Chili Pep, Oasis, there's a lot out there, and the young voice needs to be heard and wants to be heard, I think.
Okay, so the two forums then actually. There's Health and Wellbeing Board to raise the profile of it and see how we can develop that. And I think the other one that's important, of course, is the new one. And I think Mark is about to say this, it may not be, and that's the Mental Health Partnership as well. Mark? Mark?
Sorry, yeah, I was going to mention that. I was just going to come back to the previous point about the suicide prevention as well. It was sent out individually to every practice. It is on the BEST website, and Phil Ainsworth was going to give a talk at the last PCN meeting, but cancelled. He's penciling for that, so that was going to go to practice as well.
Right, so there's actually something in place, but we haven't seen it, and we're expecting the presentation from Phil. Okay, thank you. Is there anything else on the Matters Arising report? No? Okay, and can I invite Chris, please, to give us your Chief Officer's report?
Yes, morning everybody. So just in the report today, they've got quite a bit of information to pass on to governing body members, and we have got a little bit of business to do first. So Chair, what I'll do is I'll just give the highlights on the information, and then I'll direct the governing body to the business we need to look at the end. So just to start off on the report, as Jeremy referenced this earlier on, we've had the NHS 21-22 planning priorities and the operational guidance. It's very different this year. The year's been split into two halves almost. We've got a part one and a part two. So there's first 6 months and the second 6 months. So it is slightly different for obvious reasons. But the key priorities, just to flag up to governing body, are supporting the health and wellbeing staff and taking action on recruitment and retention, delivering the COVID vaccination programme, building on what we've learned from the pandemic, including the restoration of elective and cancer care and managing increasing demand on mental health services, expanding primary care capacity to improve access, local health outcomes and address health inequalities, transforming community and urgent care to prevent inappropriate tendencies to A&E, and working collaboratively across systems to deliver on these priorities. So obviously everything we'd wish to do, but it's just reinforced in the national document. So we've submitted a plan. We're just going through the process of getting feedback on that plan, and then there'll be a second iteration, and that plan will be for the first 6 months of the year, and then there'll be a process to have a plan for the second half, which is yet to be determined. So just moving on in terms of COVID-19, as the infection levels have been coming down significantly, Barnsley's down to, I think I was reading this morning about in the 40 per 100,000 incidences of positive cases. So what we've gone is from a national level 4 to a level 3. And what that means in real terms is we're moving away from the national command and control system of the NHS more to local management and accountability. We're still working obviously on a regional basis, so it doesn't actually feel very different in terms of how we operate, but just in terms of governance and accountability, moving from a level 4 to a level 3 is quite a big step. Barnsley patients shouldn't notice any difference. The next section is just around the development of our integrated care system, our South Yorkshire and Bassetlaw integrated care system. We've had some communications from Sir Andrew Cash, who's the current leader of the system. I've included, just for information, the documents that have come through, but there's 4 documents which are establishing place-based partnerships, how provider collaboratives will operate across systems, how the nature of commissioning will change, and an integrated care system operating model. So they're the things the work's specifically been looking at. Again, we'll keep the updates coming. What we're expecting is there'll be further guidance coming, probably on a regular basis, coming through as the legislation starts to form and be built up. So in terms of governing body, we'll constantly communicate the development of the integrated care system policy. And the Queen's speech did include this in the schedule for legislation for the next year. So it's now confirmed it will be part of legislation. And our expectation is still that we'll move to a 1st of April 2022 inaction of the legislation. Just moving down, so in terms of the Barsey Director of Public Health annual report, that we've received that. Obviously, we've input into that as part of being part of the Health and Wellbeing Board, but obviously it's here for our information and something that we can hopefully have our plans be coterminous with this and make sure that we're fully aligned as a Barnsley place. But just bringing us back in terms of, particularly in terms of the integrated care system development, there were 3 documents that we're asked as a governing body to give feedback on. The first is a health and care compact, which is a document which looks at the values, principles, behaviours we'd wish to work to. The second is a health and care partnership terms of reference, which we're hoping to enact in shadow form during this year, so that it will be able to take on statutory place from April 22. And then there's a place development matrix, and what that means is Barnsley as a place within an integrated care system will take on great levels of responsibility, and we have to go through a process to show that we have appropriate governance and systems in place to do that. So, Chair, would it be okay if we take them in order just to see if we could get feedback on those documents?
I think it would, because it says there feedback from governing bodies and others by the 28th of May. So this is an opportunity. Yeah, please. So
can I just start with the Health and Care Compact? Has anyone got any feedback on that document? I don't know, Nick, have you got any initial feedback? Oh, sorry, Chris, it's to you, Chair, through you, Chair.
Okay. Well, my initial feedback is I've been involved in sort of bits of work in developing that. And I'm heartened to see that there's nothing, it doesn't seem, again, a challenging document. It seems something balanced and sensible. So I'm comfortable with it. Others may not be, others may have comments. Happy to take those on board. So Chris, first of all, Chris Willington.
The only thing I would say at this moment in time is the word compact is almost contrary to what I actually looked at. There's an awful lot of people involved in the compact, and getting everyone to nod and say and agree is going to take some very strong leadership. And then, of course, as and when the legislation goes through and is confirmed, we've got to then, in our own ways, present this to the members of the public, who may find it extremely difficult to understand what is happening, why it's happening. So that's the only comment I would make as a lay member, Chair. Thank you.
Are you talking about the compact or the health and care partnership, or taking both? You're muted, Chris. Muted.
Yes, sorry. Well, yes, when I looked at the structure of the compact and the health and care partnership terms, when I looked at the whole thing, yeah, there's still a big question mark over everyone's head as to the where, the when, and how. It's not a throwaway comment, but it's how on earth, when we get to the point of legislation going through, that we actually confidently present this to the members of the public.
So I think the compact, in terms of its principles, values and things, is not a challenge. I think it's all there. I think the health and care partnership is something different, and I think it's been developed. It's an evolving document, number one, because we have to see how it works out in terms of function. But secondly, it has a large membership, and I think the idea behind that was to be inclusive and not to leave people out. So I think that's important. I think you're right, there's 50 or 60 members and there are 4 meetings per year or thereabouts. It talks about a citizens' assembly, some sort of arrangement like that as well, to get the public view. My feedback has been, not directly to the ICS, but my feedback has been to different groups, that it will be a challenge for the leadership of that group to work through how that group and its rich and diverse membership
indeed
to enact the objectives. And I think that's part of the working through that will take place over the next year or so. So yeah, that remains a challenge. And I think the wide membership is rich and diverse, and getting a consensual opinion on things will take a bit of negotiating and a bit of work. At the same time, if it's handled well, it should support strategy very well, shouldn't it? And allow us to prioritise. But there is going to be some, there are going to be rather some handling issues of the group, and I think people recognise that.
Yeah, well, where there's a will, there's a way.
Yeah. Other feedback from governing body? Or has Chris sort of encapsulated it?
So Chair, just in terms of summarising that then, so the Health and Care Compact, the values principles document, I think largely we're comfortable with that document in terms of feedback, and the Health and Care Partnership, we're feeding back that the membership, we welcome the inclusive nature of the membership. However, we would question about the ability to do business with a group of that size, and it probably will need to evolve as the business starts to flow through. Is that a fair summary?
I think so, and I think the other thing will be, as the work comes through, that may well influence the membership as well. So yeah, I think that's fair. Thanks
everyone. Just one last piece of feedback I need before we move on then is just on the place development matrix. So this is something that Jeremy and a team of partners are working on across Barnsley, and my personal feedback would be, actually it's been very helpful in terms of us, it's almost like a checklist for us to make sure that we're developing and we can do a gap analysis on where we are now and where we need to be. I don't know if Jeremy, if you've got any feedback you'd like to give to governing body.
Thanks, Chris. Just worth noting, I suppose, that we took governing body through it in some detail at the development session in April. We got some useful feedback there, which I've passed on to colleagues in the ICS as well. So it's still a developing document, but I think it is useful. And our place-based design team, thinking about the white paper and the next steps, is currently undertaking a gap analysis across our health and care system, which will help us to understand where we need to work together even more closely in the future if we're going to be ready for April 22. No other comments, though.
Do you think it's worth collating some of that feedback into our formal governing body response? Because we did have a bit of discussion at the development session, didn't we?
Happy to do that, yeah.
Yeah, and then that forms, and it was all, I think, expected stuff, wasn't it? I don't think there was anything that was beyond the boundary or, yeah, okay. Chris, have you got what you need?
Yeah, so just thanks to everybody for all that feedback. That's the business we need to do today. So if there's any other questions on any other content of the report, I'd be happy to take them.
It's not a question, it's a comment, just something for people to be aware of. In section D of the priorities and planning guidance, there are some figures for primary and community care, and it talks about 15,500 full-time equivalent PCN additional roles, and I think this is 23-24, 6,000 GPs by April 24, new GPs, and 50 million more GP appointments by 1st of April 2024. That's in the planning guidance. So my take on that is that it's very ambitious, but not out of step with previous aspirational developments. And also section D in that is described as expanding primary care. So there's a big issue around how we do that and how we train people up, how we recruit. So those issues remain with us, and these are ambitious targets, but we'll work towards them, I think, is the thought there. Okay, any other thoughts from anyone? Chris Willington.
Chair, just thinking back to what we talked about a bit earlier about jargon words and things like that. And bearing in mind we're in public, where we have a new jargon word, which is PCN. I just wonder whether, just for the sake of a couple of seconds, that you would explain to the general public what PCNs are all about. Not all about, but what they represent and where we're going forward with it.
Okay, so primary care network is a locality, a geographical area in which the GP practices and primary care agree to work together to try and improve outcomes for people in those areas over and above what they can do as individual practices. So the aim is sharing work, doing work on behalf of others. The PCN primary care network has been supported with some additional resource. These are the additional roles to try and enable that. In Barnsley we have 6 primary care networks, and they're coterminous with our community support, our community nursing services, and they come together, 6 localities or 6 primary care networks, into one primary care network, which is hosted by our GP Federation. And the ambition is that over time, additional role investment that comes to these primary care networks will help improve outcomes, but also decrease health inequalities. And the next batch of healthcare professionals that are coming through, the next resource batch, are all aimed at decreasing health inequalities. And health inequalities are where some people, for whatever reason, don't do as well with their health and well-being as others.
Thank you, Nick. Thank you.
Okay. I think that almost passes the question. It's like a Viva. Okay, so thank you for that, Chris. At that point, can we please move on to item 11, Jamie and Jeremy, COVID-19 response and recovery update.
Yeah, thank you, Chair. I'll pick this one up, and I mean, some of this is just being covered a little in Chris's Chief Officer's report in terms of where we're at the moment in terms of the National Command and Control. So I'll not repeat those bits, but I'll take you through. So just in terms of current position, we're as a country moving through the roadmap out of lockdown. So that was announced on the 22nd of February. There's been a number of steps that we've worked through already, and we're coming towards the 3rd step of that plan, which will include the opening up of more indoor venues, meeting in larger groups, attendance at large events, and potentially some opening up of international travel to some countries. So a lot more movement around, and then moving finally at the sort of mid-end of June towards opening up more fully. The government set out 4 tests that would inform whether we move between those steps. So at the bottom of page 2, there's a table there that covers the sort of indicators and the Barnsley position on those. So in terms of vaccine progress, probably a little bit more up-to-date information on that now, but I'll cover it later. But we're vaccinated now in Barnsley around 70% of the population with their first dose. So we're doing well there, and I think as a country we're doing well. Vaccine impact, seeing a reduction in the hospital admissions. At the time this paper were written, we've got 6 people in hospital. I think the position is now 3, and it continues to reduce. And those people in hospital are now tending to be people in hospital for other reasons who happen to have a COVID positive test, as opposed to what we saw earlier in the pandemic with lots of people in hospital because of COVID. So a shift there, I think that's really positive. The infection rate continues to reduce. Again, Chris earlier made reference to moving down towards the sort of 40 rate per 100,000 population. So you can see at the time we did this report, we were up at 50 odd. So again, moving in the right direction and positive. And then the 4th one is around disruption from variants. And at the moment, whilst there are variants of concern out there, they're not heavily present either in Barnsley or across the country. So I think that's a real positive for us. So that's where we are in terms of infection and the steps out of lockdown. And obviously, as we move through that, we would expect that, you know, the move from level 4 national control to level 3 regional control will at a point in time move down further to sort of give that responsibility back to local areas. So that's on the vaccine. I've also included a little bit, just because this is about recovery from COVID, on the operational planning guidance. So we've already just had a conversation around the 6 priorities, and Nick, you got into a little bit of the detail. There's a little more included in the report. So against each of the areas, there's some specific expectations. The starting with COVID, so the health and wellbeing of staff is the first priority, and that is about our workforce plans and other things, and delivery of the NHS workforce plan. But then from COVID downwards, there's some specific asks. So first dose COVID vaccination to be provided to all adults by the end of July. I think we're in a really good place for that in Barnsley, and the supply is being given to us at a rate that should enable us to get by that milestone. We've been asked to start to think about and prepare for potential revaccination from the autumn, so that might be a booster. We've not got the detail of that yet, but we need to start thinking how that might work, building on what we've learned from this first phase of the programme. So from an elective care perspective, there's an expectation that recovery levels are, elective care levels are recovered back up to 80% of what we saw in 1920. So that's where we'd need to be, and at that level, that should help us to address the long waits. So across SYB, there's an ambition to reduce the number of people who are waiting over a year for treatment down to 0 by the end of this financial year. That's a big ask, but one that I think for Barnsley we think is manageable, and hopefully for SYB is manageable. There's expectations around cancer, so recovering performance to the levels that we saw in February 2020, and increasing the number of people who are diagnosed within 28 days. So making sure that people are coming forward, seen, diagnosed quickly, and then treated quickly. So that's the other element. Continue to deliver the mental health ambitions of the long-term plan, and there's a paper later on the agenda from Patrick that will include how we're going to be doing that. Specific expectation around annual health checks for people with learning disabilities. So that's an area that we're working on, but there's a real push there, and that is an ask for the primary care networks. It's an ask for GP practices, and we're working with the council to try and support that process, and with SWIFT. Making sure that learning from death reviews take place within 6 months. So I think that's happening, but this is fairly new, and we're pushing that forward. The point that Nick referenced earlier, so supporting our primary care networks to achieve the share of 15,500, Nick, is in 21-22.
I thought it was 24. I was being
optimistic. No, it goes further than that. So it's in this next financial year across the country. So there's work to do to make sure we get them right. And then obviously the GP appointments is by 2024. So 50 million more appointments by 2024. The current position on that, we're actually seeing more GP appointments already. The combination of different models is allowing for more appointments to take place. So when you add the face-to-face with telephone and online now, the number of appointments in primary care in March is actually slightly above what they were in February 2020. So making good progress. And then the final one is around community urgent response. So an expectation that in this year, every area will have a 2-hour crisis community health response service that operates between 8 o'clock in the morning and 8 o'clock at night, 7 days a week. We've got that service embedded as part of our neighbourhoods. Spec builds on what we had as the previous crisis response service. So I think we're in a good place there. And then the final element around the planning guidance, which again has been referenced, and Jeremy made reference in the work around the integrated care partnership, is around addressing health inequalities. And we'll see our plans emerge around that and how we're going to do that. But that will be a big ask for everyone to address that. So that's the planning guidance, and they're the areas where we've been asked to focus on in terms of recovery. And then in terms of the COVID vaccination programme, so just to give an update on that and where we are currently at. So we've offered the vaccine across Barnsley to everybody who was in cohorts 1 to 9, so above 50 or with clinical conditions, and have now moved along and have been authorised to start to deliver for cohorts 10 to 12. Current position is that there's around 30% of that cohort being vaccinated so far, and we've got supply coming in over the next few weeks to help us along that sort of journey, continuing to deliver through mainly Priory campus, because that's where the biggest capacity is, but also out into the other hub sites that we've got to make sure that we can sort of be accessible to all of our communities. GP practices are continuing to support this and are currently working on the second dose vaccinations for the people that were vaccinated 11 weeks or so ago. So I think it's really positive in terms of uptake levels. The next milestone, as I said earlier, is the end of July, where we would expect everybody over 18 and those who are 16 and 17 with specific sort of conditions or who are carers to have been offered and hopefully to have taken up that vaccine. A key area that we're looking at the moment is just around making sure that nobody is left behind. So we're doing a lot of work with the council on engagement activity, working with their teams, going out, talking to local communities to understand why certain groups may not be coming forward, why people are hesitant to come forward. And I've been talking this morning around the opportunities to potentially do some drop-in open access clinics for certain groups of the population or certain age groups, just to make sure that people have got as much access as possible and that they're able to take up the vaccine if they want to. So I think that's the update for me, and happy to take any questions on that.
Do we have any questions for Jamie? No? Just one, Jamie. Booster in the autumn, is that looking realistic?
I think it is. That's the message that we're being given, that there is an expectation. They picked up in the news a couple of weeks ago the additional sort of purchases of additional doses of the Pfizer vaccine. What we've not had yet is any indication as to whether that would be a all population revaccination, whether it would be just the certain cohorts that would need to be boosted, or what model that would be. So whether there would be an expectation that primary care networks continue to sort of support and practice come together, or whether it would be wrapped up together potentially with the flu vaccine. That would need a change in guidance, because at the moment the guidance is not to have 2 vaccines within a certain time period. So there would need to be a change, but I think it is realistic. We're just not sure yet what the model will be, and I think we would need to look at the best way of doing that, because it'll be at a time when our GP practices, as they already are getting busier and busier and busier as we come towards winter.
So I think it's important to keep, as you are doing, keep an eye on that, because it'll be a different model, because most people will have had two vaccinations. Yeah.
Yes.
Secondly, it will have to be spaced by at least 7 days from the flu vac. Thirdly, we're facing the reset and recovery process as well. And fourthly, after the autumn comes the peak, busiest time for the whole system. So in your colleagues in discussions outside Barsey and at system, it would be really good if we could get some sort of handle on that, and have it would appear we'd have a little bit of time to plan for it as well. So it's not the massive disruption that it could potentially be. So we can somehow we have been forewarned, remodel it and manage it well for the people of Barnsley and for the capacity of those parts of the system that will be needing the vaccine and giving it. So there's we might be able to do this bit of it even better than the other bits. That's the aspiration.
Yep.
Are there any other thoughts or questions? No. If not, Jamie, could you take urgent and emergency care update, item 12, please?
I will. Yeah. So just to governing body members, this paper is one of the regular assurance papers. So just to provide assurance on our activities and plans against each of the priorities that we've got within our governing body assurance framework. So we bring the regular reports. So you go into the main content of the report and the introduction. I'm just giving a reminder of the key areas that are identified on our governing body assurance framework, going through from 111 through to ambulance, people coming into A&E and their waiting times, flow through the hospital, and then discharge from hospital. There's also elements around same-day emergency care, so I'll come on to our plans to address that shortly. I think we recognise from an urgent care perspective that over the last year the impact of COVID has been significant, and it's had a big impact in terms of activity levels, which have reduced significantly through the last year, but are now starting to come back, and I'll talk about that. But actually the different models in which people have been working, so because of space restrictions, the way that we've had to socially distance and things have been really challenging. So whilst we've seen lower activity, at times we've seen much longer waits in A&E. So in response to the pressures, to where we need to be, the Emergency Care Delivery Board have been developing a revised plan, and that focuses on the delivery of the priorities above. It also focuses on the delivery of the priorities that are set out in the planning guidance that we've just referenced, and local areas that have been identified. So I'll come on to what that plan entails in a second, and that's all sort of set out in section 2. So just to show and to illustrate the impact around activity levels, the first chart that you've got at the bottom of page 5 there just shows the last 4 years A&E activity. And you can see the pattern there and the impact last April when COVID was sort of just sort of beginning to emerge and have the biggest impact. People stopped coming out. We were asked to protect our NHS services. People weren't attending A&E, weren't attending other services either. But you can see that quickly as we came out of the lockdown period into last summer started to increase. Fell away again, but as you can see, February to March, the levels have increased again, and I think probably most people on the call have been involved in some of the discussions where we've noted that actually over the last few weeks, so as we've come through April and into May, the A&E department are seeing more patients than they have ever seen before. So we've had 380 patients a day on numerous days now going through the department, whilst that department is still operating in a different COVID secure model, which means that it takes more time to see patients. So we had a day last week, or maybe early, it might have been Monday this week actually, where more than 50% of the people who attended A&E waited more than 4 hours to be seen or treated. So I can't remember us being in that position previously, and if we have, it may have been an isolated occasion. So just picking up the point from earlier around experiencing pressures in the system, I think it's not just urgent care. I think that's been felt across all of it, but we can see it in the people who are now coming out and presenting with an whole range of conditions in A&E. And the second chart that's on there just gives the picture for admissions, so non-elective admissions, and that follows a similar pattern. I guess what we didn't see there, we saw the dip, less people coming in, being admitted into hospital, but obviously this would include some of the COVID infections as well. So once the numbers began to rise, it's stayed slightly below the overall position for previous years, but it's stayed up and flat across the country, across the year, sorry. And again, at February, that's then started to rise. So whilst we've seen a reduction in the COVID admissions, that has been offset and now surpassed by other people coming forward with other illnesses, other conditions that require admission. So I think it's worth noting that as the context that we're currently working in.
Jamie, I just wonder if it's worth taking the report as read. I mean, everybody's read the principles.
Yep.
This is being currently worked on and updated.
Yeah.
And we're receiving it for information and assurance. If you could pick out a couple of the points that perhaps would provide that assurance, because the other thing I'm conscious of is how many papers we've got on governing body.
Yeah, that's fine.
To get through. I think just the salient points, please, and then if other people as well presenting could do that as well.
Yeah.
Okay, thank you.
No problem. That's fine. So that's the position. I wanted to just present that as context. I think what we come on to then is the plan. So our plans to develop, and I think there's a lot of information. There's an appendix that includes that the detail of that and where we're currently at. I think it's worth just highlighting, and I'll not go through, but 4 principles that we're working on with the Urgent Care Board, and then 5 key areas where we really want to push forward. And I think whilst I've talked about the numbers and the position, I think things are familiar generally across here, but just to provide the additional assurance, I think it's around that sort of front door, what offer we've got for patients who are presenting, and just to provide additional assurance to governing body, we are working with the trust and have engaged with the emergency care improvement and support team of NHS England to come, and they came yesterday and had a walk through the A&E department. They walked through the process. They've talked to a number of individuals. So Mark, I think you had an interview conversation yesterday, didn't you? That talked to James and Merban from Barnsley Healthcare Federation as well. So that I think will give us an insight into where we might be able to do things different at the front door and different to signpost people to other services. So I think that's the key assurance, Nick. The other areas are set out there, and I'll leave it at that point.
Yeah, I just wonder, Jamie, this is quite important. It's a system challenge. It's not just a hospital challenge. It's a system challenge. It might be worth, when we next have a development session, just bringing this to be part of that session for information and discussion as well. I don't know when the next development session is, but that might give you a little bit more time to go through some of these issues. And
yeah, there's one coming shortly.
To governing body, it needn't be a long piece, but I think that would be a good place for people to think through some of these developments and how they fit together.
Yeah, we can do that. There's one coming up shortly, I think, so I can see whether we can do it there.
Okay.
Yeah, thank you.
So at this point, I can't see anybody. Are there any questions for Jamie, or shall we wait for the development session and go through this in a bit more detail? Okay, so thank you for those 2 bits, Jamie. We now move on to item 13, assurance report, primary care. Has Julie joined us?
I'm not sure she has joined us. I've just had a message from Kay saying that Julie wasn't aware that she was required for this paper. So I wondered if there was anybody else, Jamie or anyone, who was able just to again pick out the key points. It's a bit like the previous one. It's an assurance report, so it's there mainly, as I say, for information. But I don't know.
Well, I think what we could do is, sorry, Chris Millington, do you want to take us through it? Or my view is that, having read it, I didn't see anything contentious, and I haven't made any comments against part of it. So if you want to.
Chair, just coming back to, do I want to? It is here for assurance. It's very detailed. By now, every one of us should have read this paper, and I'm sure we all have read this paper. So I have nothing further to add to that. It's a pity that Julie is not with us, but these things do happen. So no, I'm quite happy. I personally am quite happy with all the bits and pieces around there, and I'm sure the rest of the governing body are too.
What we can do is take the report then as read.
Yeah.
And just ask governing body if anybody, having read it and digested it, had any areas that they wish to ask question or comment on. I don't know, Madhuri, if you feel there's anything on there you wish to highlight.
I've read the paper, Nick, and I am content with it.
Okay, so okay, so we'll accept it as assurance, and I think we'll just make a double effort next time that if Julie's done this work, we give her the opportunity to share it with us. Okay.
Yeah, I'm pretty sure that it's a communication breakdown, because I know she has been invited to come, but the invitation, I think, must have not landed at her end.
But we're in a fortunate position that people have read it and are comfortable with it, so that's good. Thank you. I think what we have now is an assurance report on mental health, and Patrick was going to do that with us.
Yeah, Patrick has said to me this morning, so Patrick's been off earlier this week, but he is back and he has indicated that he's available and joining the meeting, so I don't know whether I might be able to just invite him.
Yeah, we're a little bit ahead, so if you give him an invite, if not, we'll ask Jeremy to do 15 and then go back to 14. But we'll wait and see.
I could do 15 of that.
Yeah,
it's helpful. So again, hopefully colleagues have a chance to look at this. Again, it's an assurance report, and you can see in the body of the paper the key deliverables on the GBAF, and the assurance has been provided against each of the areas within that framework. Just want to draw governing body's attention to the shared care record, a bit more detail in the paper on that. There is a requirement set out by NHSX for us to have a basic minimum viable solution for shared care record in place by September this year. And we are currently in the process of working across Barnsley with our health and care providers and with our digital colleagues in the ICS as well, to firstly understand how close we currently are to that basic minimum viable solution and whether there are any gaps. And secondly, to develop currently 2 options in development to address that if the gaps we believe need to be addressed in the timescales that I've just indicated, September, October time. Happy to take any questions on that. Did I run through that too fast?
Yeah, slow down a bit.
I haven't any questions. Does anyone else? No. And that's there again for assurance, isn't it, and information?
It is.
Yeah. We are picking up pace a little bit here. It's one of the risks. Patrick, we're waiting for. We've received Jeremy's digital and IT update for assurance. I think then, Jamie, if it's possible, we ought to go to item 16. And Kay, could you contact Chris Lawson and just let her know we're a little bit ahead?
I will.
Because we'll need her for item 17. Okay, so if governing body's happy, we'll skip to item 16, local plastic and reconstructive surgery service. Jamie.
Yeah. Thank you. So David's joined us, so looking like he's joined us. So David's joining us as well, but I'll take us through this paper, and then if there's any questions, David will be able to input to support as well. So we're presenting this paper with a service specification for a local Barnsley-based plastics and reconstruction service at Barnsley Hospital. The ask for governing body is to approve the service specification and to note the update on service mobilisation. I'll just provide a little bit of background to this one. So the CCG were approached by Barnsley Hospital in early 2020-2021. So this has come around in a slightly different way than our usual commissioning, where we would identify a gap as such. But what this does do, and I think in line with our objectives, is it provides an additional choice for patients, and it provides an opportunity for them to have that choice to receive services in Barnsley as opposed to travelling to other areas where that better suits them. This is not about new procedures. It's not about generating new activity or new referrals. It is about just giving that additional choice. So I just assume people have read the paper, but I'll just pick out a number of key points really. So I think it's probably worth noting that whilst we're approving the spec here, as the hospital have developed the service, it did go live on the 1st of February, although it's not been sort of publicised and pushed out there. It is available on ERS. So we've got opportunities to adjust the spec, but the service is there already. I think referencing back to my point around not being new procedures, all of these procedures that would come through and all referrals are subject to the IFR process, so funding review process. I think it's important to note that that process is in place because the CCG doesn't commission routinely these sorts of treatments. But it's worth probably noting that this is not about prohibiting patients from receiving healthcare. This is about making sure that there's a robust, transparent decision making and a fairness in access to those services. So it's not a change to introduce this through the IFR process. It is as it has always been. So I think it's worth saying that. In terms of the service, so the service will be delivered. There's a jointly employed consultant who works between Mid Yorkshire and Barnsley Hospital. They are working alternate weeks and making sure that they can support. I referenced the service were launched February time, and there's space within the hospital estate to deliver this service. So I think that's there. Key point for us is around public engagement. So the process of surveying the public took place in September 2020. It's outlined in the paper, and it were on the basis of offering choice via an additional service, rather than it being an engagement on whether any services should stop, whether they should not be provided. So I think we received generally a positive response from that, albeit it was fairly light touch. The specification's been to clinical forum, so our clinical forum has had the opportunity to look at that, talk through a number of areas, including the contract arrangements, any additional costs that may come from additional activity, but I think we've got assurance that this is not about additional activity. Talked about potential to do some of this in community clinics and take things even closer to home, using potentially the lift space and other areas. And that is something that is on a development pathway, how we use those premises differently. So the hospital have said that they're happy to work towards doing some of that, but get the service in first, and that's gone back. And then the final point that I think is included in the paper and worth just noting is just the contract and financial implications. So, at this point, it's included in the paper. We're under a block contract arrangement, so we'll not have the same discussions and same contractual arrangements where we move activity, but there will be a need to have that conversation in the future, or for the providers to have that, because this will be a shift of activity potentially from one place to another, but it shouldn't lead to any additional activity or costs for Barnsley CCG. So I think that's the key points that we would want to get across. There's a copy of the specification that's been shared, and if people have got any questions on the specifics of that, either myself or hopefully David will be able to respond.
Thank you. David and Chris have joined us. So Chris Millington, your hands up, Chris.
overall, I mean, it supports our ethos of care closer to home. And if you look at the patient and public engagement section of 36 people that were asked, 35 said it's good to have a Barnsley service. So it's, as far as I'm concerned, it's a no-brainer, which is fantastic.
Any other questions or thoughts? Well, I've got one, and that is that in these changing times for the clinical commissioning group, this was a provider-led initiative. And going forward, commissioning will sit outside the CCG in some new structure locally. And I think what it does highlight to me is that whatever structure commissioning sits in, it still needs to retain a very close sensitivity to the needs of the people and needs of patients. And we might, and obviously, in some ways, this might be just a little bit before its time in view of the fact that it was a provider-led initiative. What the commissioning group always does, though, when there are these initiatives, is sense check them against the needs. And I think that's what this process has been about. So it fits our needs and fits with our values. So I think we're all quite happy to support this, and it's been through quite a bit of discussion at Clinical Forum. I think it's also been to the senior management team. I'm so happy to take any questions. If not, we're asked to note it's for assurance and to approve the service spec. Are we happy to do that? Yeah, I'm seeing nods. Okay, that's good. Thank you, Jamie.
Thank you.
Patrick hasn't joined us yet.
He's still trying, apparently. Nick is clicking madly on the link at his end, but he's not managing to connect. So
I know what that's like. So I think luckily Chris has joined us. So Chris Lawson, do you want to take us through item 17, please? Again, for the second time, noting that GP practice members have an interest in this because we receive some funding from PDA to deliver, but everything we deliver in terms of medicine optimization is also about patient safety and quality improvement in prescribing and improving outcomes. So Chris, could you do item 17 for us, please? And Madhuri as well.
Yeah. So I think I would like to just do a little bit of an introduction, and Chris will do the presentation. So just to say that, as we all know, there is a constant development and changes in the evidence base that is associated with medications that are prescribed. And I think it's very important for us to constantly review these medications that we prescribe to our patients to reduce the risk that is associated with medication prescribing itself. And we know that that risk increases with increasing age, and we are catering to about 125k population of Barnsley who are on repeat prescriptions. And it is an aging population as we move along, and hence it's very, very important that we review the medications constantly to reduce the risk and improve the outcomes to the people of Barnsley. So we also now have a lot of developments in the systems we use for prescribing, such as EPS, which is electronic prescribing system. We now have NHS apps, which enables patients to order prescriptions from home, and hence it reduces the need for them to come to the GP surgery. And that was so important through the COVID pandemic and one thing or another. Now, this has been a rolling program since 2012, and there has been a significant amount of work which is very much needed that went into it. And the content of this program is subject to engagement with GPs and local pharmacies and various other providers. And it actually does receive approval from all providers through the Barnsley Area Prescribing Committee. The program that's included in 2021-22 doesn't include all the work, just so we can leave the flexibility to prioritize as the need arises as we go through the pandemic. I'll now hand over to Chris for her to go through the details of this program.
So I think the appendix that you will see, you're seeing actually, and I hope you're seeing the same document as me, actually does, it looks quite a complex document, but as Madhvi's pointed out, it's just a focus of work that we would like to take forward. And I think it sort of is useful from the perspective of all the providers, that they can actually see what that focus of work is for the year, and that we can join up and integrate together to actually deliver, so that everybody who's in the system across all of the providers are actually working to the same aims and objectives. So it's important from that respect. What I'm going to do is just take you through one of the areas that is actually in the scheme, and there are a number of others, and all of them have a sound evidence base around them. They're all sort of quite important things to take forward, but just to give you a flavour, I just wanted to pick one, which was around inhaler prescribing. So just prior to COVID, there'd been a number of what were significant developments about inhalers. There was an introduction of something what is a triple inhaler, so a combination inhaler that had a number of ingredients to it. And we know now during COVID, it's been just so much more important that we maintain patients' lung function, that we improve their lung function, so to reduce their risk around COVID. So we want to start the piece of work that's included, which is focusing on getting as many people as we can over to these triple inhalers as fast as possible, but we obviously are dealing with the barriers and the problems around COVID. So we've got a bit of a plan that when it opens up and through the reviews, and as the reviews come online, we will actually make sure that patients get offered these triple inhalers where it's appropriate for them to have them. And the advantages of these inhalers is that rather than taking 3 inhalers, patients are only taking 1 inhaler. So it reduces their time and their effort. And also we found that patients are more compliant, so they take their reliever, their preventive medication more often than their reliever medication. And that's important if we can actually improve compliance with these inhalers. And then finally, we're doing a really good thing for the environment, because we're reducing the numbers of inhalers and we're reducing the greenhouse gases, and the carbon footprint is actually reducing as well. So it's really important piece of work. We know also that a good indicator of how well patients are doing in terms of their lung function and their control is their use of something called reliever inhalers. And so what the other piece of work associated with this is actually looking at their number of reliever inhalers when we undertake patient reviews, and targeting reviews to those that are using higher numbers of reliever inhalers. So significant amount of work going on, planned to go on around respiratory, and we'll pick that up as it opens up. The start of the work we're planning around end of June, beginning of July, and we're hoping that the majority of the work within this scheme will be able to take forward. And I could give you many more examples. I'm very excited and very driven and motivated about this piece of work, and the continuing programme, this rolling programme that we've got of improving medicines outcomes. But I think it's probably taken, it is in the paper, there's a lot of information in there, and I'll just open it up for discussion there.
Okay, so given that we're commenting on the qualitative and medical aspects of this, and that GPs will be making decisions around the funding of this, which will go to the Primary Care Commissioning Committee. Do we have any questions, thoughts, comments? No? Okay. What I would say is that this is one piece of work which sets out Barsey CCG, I think, quite separately from a lot of other CCGs in terms of the success of the medicines optimisation part of the practice delivery agreement, and overall clinical pharmacists and the medicines optimization pharmacists, both in delivering year-on-year QIP, which allows us to invest in other things to improve outcomes for the people of Barnsley. I think the biggest thing and the major thing, and it would be quite difficult for people to grasp this if they've not been on the front line, either as a prescriber, a patient, or a pharmacist, and that is that these schemes save lives, they improve the quality and safety of prescribing. And of course, a lot of those things are not easily measurable, but this is a flagship scheme for us. And congratulations to Chris, Madwy and teams for putting it together. I see Chris Millington wants to say something, so thank you, Chris and team. Chris, we've got lots of Chris's now.
Oh, is it me?
Chris Millington.
Chair, you've said everything that I was going to say. You know, I'm really switched on by passion, and Chris Lawson used that word a couple of seconds ago that she's really excited about taking this work forward, and it is so important for the people. Well, it's important for the system. It's important for Barnsley. So, Chris, well done. Just saying what you just said, basically, Chair. You've done a super job for the people of Barnsley, Chris, and I know you'll continue to do so.
Thank you. I mean, it doesn't seem, well, it seems such a short period of time since we were sitting looking at the 2021 programme just before COVID, and I think there's flexibility around this scheme. We showed that through COVID because we had to dramatically alter all of that work so that we implemented only what was safe and added value through COVID. And even through COVID, there was such a significant amount of work that was taken forward. But I don't think it's me that deserves the thanks. I think it's actually all of the primary care, healthcare professionals that get involved in actually undertaking the work to support the scheme as well, because it is a phenomenal, I describe it often as an industry, and it is like that. There's an industry there actually that is being built on to actually support patients of Barnsley with their medicines taking. Yeah.
Thank you, Chris. Any other comments, or is governing body happy to approve the qualitative parts of this medicines optimization section? Are we happy with it? Yeah. Okay. Thank you, Chris and Madwy. Thank you, everybody. So that's fantastic. And now we're joined, I think, by Patrick. Are you there, Patrick?
I am, yes, thanks, Nick.
Oh, good.
Apologies.
No, it can't be helped. I've been in the same position myself many times, as you know, but I can hear you loud and clear, which is good.
Lovely.
You want to take us through item 14, please, the mental health update assurance report.
Yes, thank you. I'll take the paper as being read, so there's just a couple of things I'd like to highlight. Firstly, that the development of the Mental Health Partnership Board and its subgroup, the Mental Health Delivery Group, I think are providing a much greater level of oversight and assurance within the local system. But also as a result, what I'm seeing is much stronger sort of local partnership collaborations developing with a much better and a greater understanding and awareness of all of the mental wellbeing issues that are impacting on our local population. In terms specifically of the children and young people, I think there's also additional enhanced oversight, which is being provided by both the Children and Young People's Emotional Health and Wellbeing Group and also by the Children and Young People's Mental Health Steering Group. So as members are aware, the Emotional Health and Wellbeing Group are focusing on the recommendations of the report that was tabled recently to governing body, and it was drafted by the Children and People's Transformation Lead. And these recommendations incorporate all of the recommendations that were highlighted by the Oversight and Scrutiny Committees earlier this year. So that work is moving and progressing. The Children and People's Mental Health Steering Group are clearly focusing on how the mental health support teams and CAMS can work strongly together and the part that they play within the system. And in respect of CAMS, we're now starting to see what was anticipated as sort of the increase in referrals. And although there is a significant increase in referrals at the moment, I think the positive aspect is that the waiting list is remaining fairly static at around sort of 60 children young people. But there are key challenges within the eating disorder service, and we're seeing a significant increase in demand on that service, so much so that the service have already received over 12 months of referrals, and we're already just in mid-May. So I think that sort of sees the impact there. That's not unique to Barnsley. So we are seeing an increase in children and people's eating disorder services throughout, certainly South Yorkshire, but I suspect it's reflective both of Yorkshire and Humber and nationally. So we just really need to keep an eye on that. We are seeing significant challenges within the IAPT service. So I think I've outlined some of the issues in terms of the access target. The service are continually and actively promoting the service, but there is a sense that there may be an even more significant increase in demand for the IAPT services. So I think there's anticipated demand anyway, generally, for IAPT services. Add to that the potential sort of suppressed demand because of COVID, but then add to that additional demand because of the consequence of COVID, and we're expecting quite a significant increase for that service. We are seeing that already. So in March, the service received over 700 referrals, and that's nearly double the amount they would normally see. That increase is continuing, and in April, we saw over 600 referrals into the service. Clearly, the investment that's been agreed will have some capacity, but it does take time for that capacity because of the training and everything else that has to happen. So it will be something we need to keep a look on. The impact currently is that the initial waiting time from referral to first appointment has been increased from just under 2 weeks, and it's now between 4 and 5 weeks. So it is something that we do need to be aware of, we need to keep an eye on. And it is something that I will continue to report on as well. But finally, positively, the Barnsley Early Intervention Psychosis team are currently the top performing team in the country. So I think that's also worthwhile adding as well. So there are a number of challenges there. I've outlined a number of things in the paper. So if anyone has any questions in relating to any of that, then I'm happy to take them now.
Okay, Mark, do you want to make any comment? No. Okay. A couple of things then.
I'll unmute myself. No,
go on, Mark.
Sorry, nothing. No, I've nothing particularly to add to that. No.
Nigel Bell.
Yeah, thanks, Nick. I was just going to reflect on the conversation we had at Finance and Performance Committee, because while all this seems reasonably positive and I'm really pleased about that, there were some questions raised about accessibility of referral slots for young children who were suffering stress, etc. And I know that you do put in that you're trying to develop a 0 to 25 service, and I definitely welcome that. But I do wonder whether some of those issues that we raised at FMP, which obviously you weren't at, Patrick, so you couldn't predict them, but whether they ought to be reported back to us at some point in the future, just so that we're assured that, although this looks positive, everything that concerns are being covered.
Okay, so clearly, obviously, I wasn't there, Nigel, but I will pick up those issues that were highlighted through the minutes, and I will report back on those for members of Finance and Performance.
Okay, thanks, Patrick.
Thank you, Nigel. Jamie? Mute.
Apologies. Just to follow Nigel's point, and just for clarity for governing body members who weren't there. So this was around accessibility for children and young people, Patrick, and it wasn't specifically aimed at CAMS. I think we were discussing, because there were an update on the children's executive group, and there were talk around CAMS and the reducing access. So it wasn't around that specifically, it was around people who might, so young children who might have needs that are akin to adults who access IAPT services. So what is the offer for them? And so sometimes them referrals might go to CAMS or elsewhere, and they're maybe not the right service to meet them needs, so they bounce back. So it's a bit about the SPA, that single offer, that assessment. If a referral's made, giving it the assurance that that'll be picked up, and that the children and young people, their needs will be assessed and they'll be met by the right service in that place. So I think it was some of that was discussed, because our GPs are still receiving a number of, and if more referrals are going through, then they'll be getting more letters back. And it's when the letter comes back, what do we do next? So it was that sort of thing that were being picked up around children's, really.
Okay, so I think some of those issues will obviously be incorporated within the work of the emotional health and wellbeing group. So that is the system wide and looks at some of the early help assessments and that type of thing. So we're looking at how that can develop into the one, as you said, the one single point of contact. So the initial starter with the single point of contact is between MHST and CAMS, and then we'll develop that further to the wider system. So, but I will pick up specifically on some of those points and inform members of what the sort of work is and how things will work in terms of those referrals and how they get bounced around the system, etc.
Patrick, can I ask you? Oh, sorry, Mark Smith.
So will the mental health support teams play a part in that as well? The new teams in schools?
They will, and I suppose that at the moment, because of the way that the Trailblazer team is positioned, so that a number of the practitioners are currently, half of their time is spent at university. So there's currently a reduction in capacity of that team, although they are still providing a service. But clearly, when they come on board fully in sort of like 8 to 10 months' time, there will be a much better service provided. So although there is a service provided, it's not at capacity currently because of the training issues.
Okay. So I had a couple of points, Patrick. I think the first one is earlier in this meeting, we talked about engaging with young people and children in terms of commissioning and developing strategy. And am I right in understanding from what you've said that the Children's Mental Health Steering Group is plugged in to the Mental Health Partnership?
It is. It
Right.
is through myself and through the transformation lead, Lauren Nixon.
Right. So the Mental Health Partnership is hearing the voice of young people. Yeah.
It is, and the CCG, we commissioned Chili Pep to specifically engage and consult with our children and young people as well, and the council commissioned this sort of youth council and other forums specifically. So there's lots of engagement in terms of children and young people, and their voice is heard.
Yeah. So one of the things we might develop is having that voice heard at the Health and Wellbeing Board, for example.
Yeah.
Periodically it is already, but there's a more regular perspective.
Yeah.
The other thing is, looking through the paper, there's an eating disorders task and finish group.
There is.
That's how will we be kept aware of what's happening there? Because you mentioned a long waiting list and increased referral.
Yeah. So the eating disorder has been sort of developed because it was an issue that was put through initially through the mental health delivery group. So with all the intelligence data that's coming through, it's highlighted as one of the issues where we don't do as well as our neighbours, perhaps. So linked to that, there's also the work that's from the steering group, specifically about the challenges of eating disorders and the CAMS pathway. So it's myself and Lauren Nixon, again, Young People's Transformation Lead, who are leading that work. And I'm presenting a deep dive into the issues in terms of eating disorders to the delivery group and the partnership in June. And obviously the governing body will be kept informed of those issues as we move forward. So it is linked in with both myself and Lauren Nixon and the wider system. So we have Sahida, with the South Yorkshire Eating Disorder Association, part of that group. We have clearly CAMS as part of that group, and the mental health support teams are part of that group, and other voluntary sectors as well.
Okay. Any other questions or thoughts to discuss or share with Patrick? Or okay. So thank you, Patrick. And I think what was brought up by Nigel is you're going to feed back to F&P about issues that were raised there.
I will.
Okay. Thank you, Patrick.
Thank you, and apologies for the delay.
Pleasure. Okay, so we skip forward now and we go to item 18, Quality Highlights Report. Jane, please.
Okay, thank you, Chair. Apologies to the public and to the governing body if my dog barks during this agenda item. She's a little bit unsettled this morning, so apologies for that. So the Quality Highlights Report, the Quality and Patient Safety Committee met on the 15th of April and would like 6 quality issues to be highlighted to the governing body for information and assurance. The first one is safeguarding, which the committee rated as green. The committee was provided with a comprehensive update on safeguarding adults and children for assurance. And the committee was assured that safeguarding requirements continued to be met despite the ongoing impact of COVID-19. The second, patient experience, so sorry about this, again RAG rated as green. The committee received for assurance the quarterly patient experience report for Q3 of 2020-21 and noted the significant increase in complaints and concerns compared with the previous 2 quarters of 2020-21, and this was largely due to issues relating to COVID-19. The committee was assured that complaints and concerns received by the quality team were being managed effectively and that learning from those, most importantly from those complaints, had been acted upon. The third, the South Yorkshire and Bassett Law Quit patient group direction, the committee RAG rated as green, and this was presented for approval by Chris Lawson, our head of medicines optimisation. The committee approved and adopted the standard patient group direction for Varenicline supply as part of the QUIT programme, and for noting the QUIT programme commenced on the 1st of May. The fourth is the emerging SWIFT waiting list, which the committee RAG rated as amber. So the committee was briefed on some emerging waiting lists in SWIFT's community services, namely dietetic service for older people and the adult epilepsy service. Now, these had previously been discussed at the SWIFT's Clinical Quality Board, where reassurance had been provided by SWIFT that actions were being taken to manage the waiting lists. The committee agreed, because obviously we have got an issue with the adult speech and language therapy waiting list, that the waiting list should be monitored and further assurance is sought by the SWIFT Clinical Quality Board. The fifth quality highlight for the governing body is minimising harm updates to planned care and cancer pathways, which the committee RAG rated as amber. So the committee was provided with an update on the actions being taken to minimise the risk to patients on quality and clinical effectiveness and patient safety due to the impacts of the coronavirus pandemic on the delivery of elective planned care and cancer pathways. And the committee, from the paper and the discussions we had, were assured on the content and progress described within the reports. And finally, the adult speech and language therapy service, which the committee RAG rated as red. So the committee was notified of the latest position with regards to SWIFT's adult community speech and language therapy service waiting list. So the service is still not able to receive new referrals, and the CCG, although we've tried, we've not been able to seek support with new referrals from other providers across South Yorkshire and Bassett Law due to their own capacity limits. So the committee was advised that the waiting list backlog will be managed by the SWIFT's stroke team, and the CCG will be conducting a review of both the adult and children's speech and language therapy services in the future. So the committee noted the latest position and agreed that community services should be included in the minimising harm programme, as their services impacted on patients with long-term conditions. The committee also agreed that further assurances are required from SWIFT to ensure that they are clinically prioritising patients who are on the waiting lists in line with NHS 2021-22 priorities and the operational planning guidance. So 6 quality issues highlighted to the governing body, and I'm happy to take any questions.
Questions? No, not seeing any hands. Okay, thank you, Jane. So you feel confident around SALT that the stroke team and others will get on top of this eventually?
Yes, there's obviously work going on with SWIFT with regards to the speech and language therapies, the posts, as well as the waiting list, to make sure that they are being clinically prioritised, that we are contacting patients, because that was an issue, that they weren't contacting patients who were put on the waiting list. So we are assured that they are prioritised now and referred to other services if they can be, but we are working with it from a contract perspective.
Yeah, because as a GP, what I do see is lots of people wanting to access this service, and we often prescribe high-calorie drinks and things like that for them. And actually, they can sometimes swallow the tablets and sometimes eat a proper meal. So some of the referrals, yeah, they probably need some advice, but they're not as complex as some people who can't survive without getting the nutrition they need. So there is something about prioritising, isn't there?
Yeah, yeah.
Okay, thank you, Jane. Thank you for that.
Thanks, Chair. Thank you.
If there are no further questions, Richard, I'm going to invite you to do the item 19, Risk and Governance Exception Report. And in that we've got the Assurance Framework, the Risk Register and the Committee Effectiveness Report, which is always interesting. Thank you.
Indeed. Yeah, thank you, Nick. So again, I'll take the report as read, and I think all of the items on it are there really for information and assurance. So I'll just confine myself to just a few comments, just picking out a few of the highlights. So as you say, GBAF and Risk Register are on there just for assurance this month. There are no proposed sort of changes or additions to those risks that are on there. You have in your papers our Q4 workforce report. This is a report that we get from our HR team, which tells us about things like staff sickness absence levels, staff turnover, and compliance with training requirements and so on. And generally speaking, that provides us with assurance, if you like, that we're currently experiencing low turnover and low sickness absence. The one thing that maybe I would just point out there is the mandatory and statutory training levels, which are currently generally speaking at sort of amber. That's not bad, you know, that means 80% or more of CCG staff have done them, but we like to see those up at green whenever possible. So we've been taking actions through senior management team to try to make sure that next time we get this report, we've got those numbers back up into the green where we want them to be. And the one that I'm particularly sort of exercised about at the moment is the data security and protection toolkit numbers, because as I'll come on to say next, we need to get those up to 95% to make sure that we meet the requirements of the toolkit. On that topic, there's also a reference in the paper to the data security and protection toolkit. This is, as members will recall, we have to do a self-assessment for the toolkit every year to provide assurance that we are meeting all the standards and requirements placed on us around information governance and data security. This is just to assure governing body that we've now had our annual audit relevant to that. So our auditors look at a sample of the evidence that we're providing for that, and they were very happy with the work that we'd done. We got a substantial assurance opinion for that, which was great. So that means that I'm now, you know, nicely confident that we'll be in a position to submit that with a sort of fully compliant assessment by the deadline, which is the 30th of June. We've got a Quality and Patient Safety Committee in a week or two before we do that, so I'll just provide a sort of final update to Qpsc, and then we'll go ahead and sign off unless something unexpected happens by the end of June. There's also reference in the report to the annual report and accounts. That this is again just to assure governing body that we have submitted our draft annual report and accounts on the 26th of April, which is in line with NHS England requirements. They're now currently sitting with our auditors who are doing their usual thorough audit work on them, and we will reflect any changes or recommendations that the auditors make in the final version of those documents, which will be going to audit committee and governing body for final sign off in June. So that's just a marquee card that we'll be bringing those back on. I think it's the 10th of June for final approval. You've got in your pack the committee assurance reports. These are every committee every year produces a report just to provide assurance to the chief officer and to the governing body that the committees have covered off their terms of reference and have operated in a way which is as I say, as set out in the terms of ref. All of those have been through the committees themselves and through the audit committee, so these are just here really for, as I say, for your information and assurance, and as part of that whole suite of information that governing body receives through the year-end processes. And then the final thing, as Nick alluded to when he invited me to present the paper, is that we've done the committee effectiveness survey this year. So we've sent out a survey to everybody who's a member of one or more of our committees, asking them for their views on how they operate. You know, do they, in terms of the quality of the papers, timeliness of the papers, and those sorts of things. And a summary of the results are in the pack there. It's generally speaking a positive picture. People seem to be content that the committees have continued to work pretty well this year, which is gratifying. There's some quite interesting comments in there that you might have seen about the way that doing things virtually through Teams and so on has worked this year. Quite a lot of fairly positive things that people have liked about it, and the way that it's allowed us to keep doing the business in quite an effective way through the year. Obviously, one or two people are saying that they find the ability to read body language and so on in sort of face-to-face situations is something that inevitably we've lacked this year. So some mixed views, but generally speaking, fairly positive about that, and we can reflect on those perhaps as the government's sort of roadmap out of COVID progresses, and we may at some point be in a position to think again about how we run these meetings, really. So some food for thought, really. So that was all I was gonna say. Happy to take any comments or questions. Otherwise, as I say, the paper and the appendices are really just committed to governing body for your information and assurance.
Okay, so quite a lot in that report. So I'll invite governing body their thoughts on any of the items and any questions. Richard. Goodness me. Is this the effect of Teams, do you think, Richard? Yeah. Compatible with some of those comments?
It's just such a thorough and comprehensive paper, Nick. There's nothing more to be said, really.
You want to formally take us through the ask. Before you do, I think there's something for me in the risk register about the CHC risk, but I think we're due to receive more information in a later meeting, so yeah. We can pick that up there, I think.
Okay, that's fine, thank you. So yeah, in terms of the ask, so we're asked to review the assurance framework and risk register and consider whether all risks are being appropriately managed and scored, and identify any potential new risks for removal. I'm taking it from the absence of comments that people are happy to do that. And then we're asked to note the rest of the paper. So note the toolkit update, note the Q4 workforce report, note the committee annual assurance reports, note the findings from the committee effectiveness survey. Oh, sorry, there was one that I missed, wasn't there? Which was the data quality policy. Many apologies for that. So we have a data quality policy. We've reviewed it. That was Jamie and myself, and Paige has worked with us on that as well. We made virtually no sort of changes, certainly no significant changes, but we just wanted you know, to inform governing body that process had happened. So that's there for governing body to note as well. So sorry about that.
Right, that's fine. So I think we have to say a big thank you to Richard, because he does this for every governing body meeting. There's quite a lot of stuff there, quite a lot of detail, all to keep us safe. So thank you, Richard.
Thank you.
And your reward is 820.
I'm on again, aren't I? So I'm happy to present the paper. If there's any sort of detailed questions on the three items, I might have to defer to colleagues who might have slightly more sort of knowledge of that. But essentially, since the last meeting of the governing body, we've taken effectively 3 decisions under the sort of urgent decision-making provisions that we have in our standing orders. And what happens then when we've taken an urgent decision is that they have to come back to the next meeting for governing body to ratify. So that's the ask of governing body is to ratify these. So there are 3 items. One is around an extension to the contract for the desk row service. This is North of England Commissioning Support is sort of empowered to take patient identifiable data and process it and de-identify it on our behalf so that it can then be provided through to the CCG for us to use for our commissioning decisions and for our invoice validation processes and that kind of thing. So there's been a decision taken to extend that contract. Next has been doing it basically since the start of the CCG. Do it well, and so that has been extended for a further period. We've had a decision taken to provide some information to our external auditors about the mental health investment standard, which has been signed off as I understand it, and we've been given a clean bill of health on that. But before KPMG was able to do that, we were asked to provide them with some documents which Audit Committee requested governing body had sight of and was able to sign off on before we sent them through. So we've got that one. And then the third urgent decision was around some proposals around the assessment and treatment unit reconfiguration. And the decision-making body there was a joint committee of West Yorkshire CCGs, which we haven't actually made any delegation into. So it was necessary before. I think it was Jamie who attended that meeting on our behalf. It was necessary that he went into that meeting with sort of the support of the governing body for the proposals, if you like. So again, that was done through a virtual decision-making process. So those are the three items. As I say, happy to take any questions if there are any. Otherwise, the ask is for governing body just to ratify those three decisions.
Is governing body happy to ratify those three decisions? No. Yeah. Okay. Thank you. Thanks, Richard.
Thank you.
So we then move on to item 21, which is the IPR Integrated Performance Report. I wonder, Jamie, if you could do the performance first, and then Roxana could do the financial position and lead into 22. Is that item 22? Is that okay?
Yeah, that's absolutely fine. Thank you. So from a performance perspective, you've got the sort of month 12 position where that's available. In a number of indicators we're still reporting the month previous, so not quite taking us to the end of 2021. The report continues to show the adverse impact of COVID, and I think some of the challenges that we're going to face over the next year or so, and sort of reflects the areas that are highlighted earlier, that we highlighted earlier on the agenda around recovery and reset. So picking out a few of those from the dashboard, some of the constitution standards around referral to treatment time and waiting time for diagnostics, starting to see a little bit of improvement against the sort of previously reported position, but we're still seeing high numbers of people waiting longer than 18 weeks. We're still seeing higher numbers of people waiting for diagnostic treatment longer than 6 weeks. I think I did just flag out in the report there that our performance for Barnsley patients was the highest in March since April 2020. So, you know, it's gone through that dip, but we're back to that level in terms of, well, or coming back towards that level. So we've had a year of poor performance, but we're now on an improvement trajectory. Urgent care, I've touched on earlier in terms of A&E performance, impact of increasing activity, so I'll not go into that too much. Cancer pathways, so we're seeing on the back of diagnostic issues and others some challenges with maintaining those pathways. So the 2-week wait performance does continue to be good, so people are getting in quickly once they've been referred for urgent referral, but the number of people who are then able to receive a diagnosis quick enough and be referred on and receive their treatment within 62 days, the number of them people over 62 is increasing. So work needs to continue to address that from a cancer perspective. And then from an IAPT perspective, I think we saw some improvement in March, and Patrick's just referenced the increase in numbers coming forward for that service. So we've been challenged through this year in terms of achieving the access rate, which is the numbers coming into service, but our waiting times, as you would expect when you've got lower numbers, have been good. And I think what Patrick started to indicate, and we might see in the data, is that the numbers will come up, the access rate will improve, but we need to be mindful of how that impacts on waiting lists and people coming into the service. And then I guess just for the year, it's worth flagging that the national expectation is that year on year we see an increase in the access rate, and actually in 2021, probably linked to COVID, we didn't see any increase. So usually we have seen an increase year on year, but the increase in the access rate didn't occur in 2021. And that's all I wanted to pull out from a performance perspective.
Can you just confirm, Jamie, this performance and delivery report is for May 2021 meeting?
Yeah, what does it say on it?
2020.
Says what on it, sorry?
2020 on the one.
Oh yeah, it should be 2021, so apologies, I'd missed that. I missed
it until just now. Are there any questions for Jamie on our performance? Doesn't look like there are. Okay, thank you, Jamie. Roxana?
Yep, thank you, Chair. So I'll briefly take us through the IPR report. Not much in the way of change in terms of the financial position. The CCG did deliver financial duties for the year ended 31st March 21 with a surplus position of 195,000. That 195,000 was delivered due to some allocations received for independent sector funding and hospital discharge programme. So we closed the accounts off, containing those costs within our overall allocation, and then we received some late allocations from NHS England. So that's just to note for the governing body. Obviously those numbers are subject to audit. We've got the auditors in currently, and we have a closure meeting with them next Thursday. So I've got a meeting with them next Thursday to kind of pick up any sort of items that they wish to discuss with us. But so far we're not getting any issues coming up through the audit.
So just to clarify, so governing body understand this, for the year ending 21, we've hit financial balance.
Yes.
Good. So therefore, as a governing body, we express thanks to you and your team for helping us achieve that. So thank you.
Thank you. The headline, all the information is contained in the report in terms of the pressures that we experience as a CCG. There's no change in those, so they tend to be around prescribing and continuing healthcare, as previously reported to the governing body. Finance Performance Committee did consider and review the detailed outturn position last week at the last meeting, and there's nothing significant for the governing body to note. And at that point, I'll pause and take any questions on the integrated performance report.
Nigel, anything you? Okay. All right. Thank you, Roxana. Thank you once again. Thanks to you and your team. Thank you, Jamie, for your part of the report. I don't know what that was. Can you move us on to item 22, please, Roxana?
Yep. So as the governing body is aware, 21-22 is broken into two halves, which are known as H1 and H2. So H1 takes us to the period 30th of September 2021, and then H2 will commence 1st of October to the 31st of March 22. The paper sets out the financial framework and the assumptions that we've made within our financial plan for H1. So that's to the period 30th of September. Section 5.2 does include a detailed list for the governing body of those assumptions included in the plan. These were agreed and discussed at the Finance and Performance Committee prior to submission of the financial plan. And it's important that the governing body note that. Also in section 5.3 of the report, it sets out the allocations that were received by the CCG for the first 6 months of the year. So that includes 253.7 million, which does include some provider top-up funding, which is essentially what was the Provider Recovery Fund previously. So it was called PSF previously. So it's just, there has been some changes in funding flows, which does mean that the CCG's allocations have increased. It also includes some funding and some resource for COVID. So we still continue to receive resource through our ICS to respond to COVID-19. Section 5.4 sets out the level of efficiency and the risk included within the plan, and this was discussed in quite a bit of detail at our Finance Performance Committee, particularly given the level of unidentified QIP that we still have within our plan of 4.66 million. We will discuss that later as a governing body in our private session later today around how we potentially mitigate against that risk in order to deliver financial balance. But it's important to note that position. Section 5.5 is the summary of the budget to be approved, and that the detail again was considered by the Finance Performance Committee at the last meeting, and the Finance Performance Committee did support the recommendation that the governing body approves the budget position presented here today. So the ask is that the governing body approve the budget for H1, noting the level of unidentified efficiency and identify any potential mitigating actions, which we'll discuss later today. Take any questions. No? Thank you.
No questions. So we're then approving the budgets from April to September 2021. Thank you. Thanks, Roxana. Can we then move on, please? We've got a series of committee reports and minutes. So taking those in order, we've got minutes of the Membership Council, which are draft of 21st of April. So happy to take any questions on those. Okay, if not, we move to the draft minutes of the Audit Committee held on the 22nd of April, I think.
That's right. We reviewed the draft annual report and accounts, account forward plan, the committee's assurance reports, which you received earlier this meeting, and the value for money audit plan from KPMG. Otherwise, I'll take any questions.
No questions. Thank you, Nigel. So we then move on to minutes of finance performance, which have both been adopted 4th of March, 1st of April. So they're really there for information. Happy to take any questions if there are any. Okay. So then we've got the primary care commissioning highlights report with the minutes of the 25th of March. Chris. Anything to...
Thank you, Chair. The January 28th meeting, the minutes have been adopted, so I won't take through that unless anybody has any specifics on it. The 13th of May, 2 items really, GP survey. Very comprehensive survey, and as you know, it's done by each GP location. We looked at and identified the trends and themes within the GP survey, and the primary care team continued to monitor and support all our GP practices' delivery of services and performance across Barnsley. Second point was, since 2018-19, NHS England has required independent assurances to be provided that primary care delegated functions to the CCG have been appropriately discharged. There are 4 domains: commissioning, procurement, contract oversight, primary care finance and governance. An independent 360 assurance has undertaken this year's audit, and the report includes 2 areas of low risk. That includes actions to mitigate the risk that will be implemented by our head of primary care and the primary care team. happy to take any further questions.
Do you have any? No, thank you then, Chris. Then I think we've got the adopted minutes of Quality and Patient Safety Committee of the 18th of February. We've had the highlights report earlier. Madwy or Jane, is there anything you wish to draw out of this, or no, just there for information, just to be sure? Okay, thank you. So then we go on to the reports that were circulated in advance for noting, and you'll have received and noted those. 25, reflection on how well the meeting's business has been conducted. I think we managed fine. I thought this would be a much longer meeting. I don't know why it's so quick. Apologies if it's been too quick, but I think everyone's had opportunity to engage. And at that point, if there's no other item that people wish to bring up, we'll close the meeting and we'll exclude members of the public with the governing body's permission and move to the private section of the meeting. Thanking the people of Barnsley for attendance, viewing, and also the governing body members, and Kay for her usual diligence in helping us prepare and execute this meeting. So I think we should close the meeting. Are we all right to start the next at 12 o'clock? Is that okay?